The Maryland Healthcare Commission will now come to order. We have a number of commissioners on the line. I'd like the commissioners to identify themselves, please, on the line.
This is Commissioner Stephen Thomas here.
Jeff Metz here.
Commissioner O'Connor here.
Commissioner O'Connor. Anyone else? Okay. Thank you very much. All right. Ladies and gentlemen, included in your packets are the copies of the minutes from our September 20th, 2018 public meeting. I'd like to entertain a motion to approve the minutes. We'll have a motion. One motion. So moved. Okay. Commissioner Peters. Any discussion? All in favor, say aye. Oh, excuse me.
Aye.
Excuse me. Mistake. Go ahead. Commissioner Boyle, you had a question. Okay, I think that's a fair point. What I would suggest then is that the staff include, going over the record, any reference to the insurance in the minutes, and we will incorporate that in the minutes. All right? Okay. Go ahead.
I guess it was really about the results of the public grant study. I'm really not sure that's the appropriate place to have that.
Well, the point is, if the discussion took place, there is a record of it, and we can simply reference that conversation. Right. Yeah. Mr. Director.
So I think, my recollection's a little foggy on that. I mean, I think we want to correctly portray what happened, and then we'll go back and look at the recording of that and appropriately report what was heard. I think the purpose of the grants were not test whether they could be covered by insurance benefits, or rather whether they were care delivery alternatives. But we'll look into that. What we can do.
Yes, and the key thing here, I'm very, very glad you raised it. The key thing is to make sure that the minutes of the commission are accurate and they reflect exactly what went on. So I appreciate the question. It is important to make, of course, for all of us, it's important to make sure that when we look over the minutes, that what we're dealing with here is substance. There are certain things that are said that are not necessarily relevant to the conversation of the commission. In any event, is there any further discussion? We have a motion. We have a second. All those in favor of accepting the minutes say aye.
Aye.
Any opposed? Okay, thank you very much. Commissioners, you've all received the written updates from our centers, and you had a chance to read them. You've had a chance to examine them. Commissioners, do any of you have any questions on the written updates that you've received from the staff? Yes, Commissioner Tamarchio.
I'm going to refer to page 3 in regards to the uncompensated care payments for trauma physicians.
Mm-hmm.
Noticing the volatility of the numbers, is there thought as far as what's happening, or is there anything that could be addressed?
So in terms of the uncompensated care payments that we made, we shut down the processing for 3 months while we re-engineered the software that's used here to take the information that our vendor Core Source submits to us. So we held back claims for 3 months until it was the software had been modified. At the end of last month, the claims that had been these uncompensated care claims that we'd held, not satisfied that the the software was generating the correct reports for practices and submitting this information to the comptroller for payment. And I think we've resolved that issue. We still have some improvements to make in the processing of uncompensated care funds related to the acquisition of, for that system, what we quote unquote call the eligibility file, which is actually the Maryland Institute for Emergency Medical Services Systems trauma registry. Remember that to qualify for uncompensated care, it has to be a patient that's on the registry. So we use that as an eligibility file. And we're resolving some issues that have built up over time. And that's going to be the next area of improvement. But the fact that we didn't pay uncompensated care claims for 3 months is due to the software glitches. Now, all that said, we do see some variability month to month in the volume of trauma claims that are submitted because this is the trauma fund, if you will, is the payer of last resort. So in some instances, amongst small practices, they will hold claims back and submit them in a batch format. And so you will see some fluctuation in claim volume, even if they are operating in a predictable manner. We should see the practices should see some improvement in that process moving forward because it will enable us to more fully report the patients for the uncompensated care payments that we make.
You're expecting some stability in the.
Yes, I think we're expecting some stability, but keep in mind that compared to 2014 and prior years, that as a result of the ACA and principally Medicaid expansion, actually, more than anything else, that the volume of uncompensated care has declined significantly compared to what it was in 2014 and prior years. Because hospitals can qualify patients for Medicaid when they arrive uninsured, whereas in previous years, the relatively limited benefit that was available for individuals, adults without adults low incomes, they fell into the ranks of the uncompensated. Today, that's much less likely.
So again, we're anticipating the numbers to become more stable, but definitely lower than 2014, or probably what 2016 and 17 being the.
I would say that
correct numbers.
That I don't have those numbers in front of me, but one of the uncompensated care payments probably are going to operate at about 2017 levels going forward, assuming the commission doesn't take any action to adjust the actual reimbursement level. Uncompensated trauma fund really was intended to address three particular needs when it was adopted in 2003. One was on-call payments for physicians who worked in level 2 and level 3 trauma centers that didn't necessarily see a lot of trauma care, but had to be at the facility or be available to respond to that facility, and therefore were experiencing significant reductions in the number of patients that they could see at their offices. That was one leg. The second leg was for Medicaid shortfalls. During that period of time, Medicaid reimbursement was about 70 to 75% of what Medicare paid. And as a result of the bill, Medicaid reimbursement for trauma care was raised to 100%. And then uncompensated care, which represented the third leg of payment, And of course, that wasn't paid at all. Hospitals through the hospital rate setting system had historically been covered for their uncompensated care losses in trauma and elsewhere, but physicians that provided care were not. So they were, we set up a formula through which they would be paid at 100% of Medicare. It was raised to 105% in, I believe, 2014, and we're continuing to look at that going forward. So sort of an exhaustive explanation, but what we've seen is that the leg pertaining to uncompensated care has dropped rather precipitously as a result of broader health system reform.
Thank you.
Thank you very much. Commissioners, do you have any other questions? Any questions from the commissioners? Any questions? Mr. Director, do you have any additional updates?
So interestingly, Commissioner Marchio did pick out one area I was going to update you on. I'll skip that, thinking everyone has heard enough. But I did want to very briefly summarize the work groups that are going forward, either they're as a result of statutory changes adopted in the 2018 session of the legislature, or as a result of requests that we received from the standing committees to do something. First off, the EMS reimbursement work group for new delivery models. There has been some success in developing mobile integrated health here in the state of Maryland, and the Healthcare Commission, WIMS, and other state partners are working together to determine if a broader initiative can be launched to support these types of reforms going forward. We expect that we will have a report presented to the Commission in December on that, and that report then will be delivered to the legislature in January. A second work group that was authorized as a result of legislation in 2018 is the African American and Rural Community Infant Mortality Study. We've had an initial meeting. It's a very broad study area, and we've determined that we need to break into some work groups. We'll be relying on the expertise within the department. The Office of Health Disparities and the Office of Infant and Maternal Health are going to play leading roles in this, and we'll also be relying on input from stakeholders and academia to help us develop the recommendations for improving infant mortality here in the state of Maryland. Fortunately, that report's not due until November of 2019 because there's considerable work to do. Turning to some health IT activities, there is a health record and payment integration program advisory committee that is working on how payment and clinical information can be integrated. We had some nascent experiments in that several years ago, which highlighted some challenges on combining clinical and administrative information, but we're going to make another stab at that. The report will be due in November of 2019. This work group is really actively engaged in efforts currently, and there's some good ideas, but we're also seeing quite a few challenges. Finally, on electronic, another health IT initiative on electronic prescription records integration. As many of you know, the state of Maryland has a pharmacy management system in which controlled substances are reported from prescribers and dispensers. The thought was that that information that system could be used broadly to enable the sharing of pharmacy information with all clinicians. We now have made sufficient progress to determine that probably the state infrastructure through the PDMP program is not appropriate, but are looking at some of the other alternatives that might exist, including some private sector solutions that report, we have more than almost more than 2 years to spend on developing it. But there's a good deal of enthusiasm, but we're also finding encountering significant challenges. Lastly, on our turning to work groups that are triggered by requests from the chairs of the respective standing committees. Certainly the one we're most focused on is the CON task force. Of course, we've been meeting monthly for more than 8 months now. We expect to have a set of draft recommendations to the commission at the next meeting in November. What I would say is that the discussions have been very valuable and thoughtful on the part of the stakeholders that have participated. Not surprising, however, I think most of the representatives have looked pretty narrowly at their own specific interests. And as we think about this, Chairman Sargent and staff have reminded the stakeholders that certainly the commission wants to think broadly about potential reforms in the CON arena, recognizing that we will be, in some instances, needing to make these changes in a step-by-step process, but keeping in mind that there needs to be, as we move into the next phase of healthcare reform, a loosening of some of the constraints on participation in the healthcare arena that will be beneficial, we all believe, to all Maryland residents. Lastly, we have a couple other activities, one of which you'll hear today about the physician maintenance of certification, and also a telehealth, school-based telehealth study that is now underway. We have grants in process that will inform us on the feasibility of some of these initiatives, and we expect a report on that in November of 2019. Turning very briefly to the total cost of care activities that we are engaged with, we have 2 staff members that are working on really the next phase of the total cost of care effort, which is identification of innovative models that can be developed and linked to the hospital global budget revenue initiatives, and they involve engaging other practitioners, healthcare providers, including nursing homes, hospices, home health agencies. We are participating in this broad stakeholder group. The focus of that is to develop attractive alternatives that may have been presented here in the state previously. For example, one is the community-based oncology model. Others focus on models that have been successful across the country, but have not been allowed to date here in Maryland. So it's really developing as many ideas as possible, and then funneling them to respective state decision makers, be they the Department of Health, HSCRC, and perhaps even NHCC, to determine if they're viable to launch and go forward. Melanie Cavalier and Megan Renfrew are participating on that group. Also, lastly, on the primary care initiative that was launched this summer with considerable excitement. We now know that over almost 600 practices applied, and it looks like a good number, perhaps as many as in excess of 575 practices will be judged qualified to participate in this program, which launches on January 1. There are more than 20 care transformation organizations, these organizations that would assist practices, if needed, meet the advanced care delivery requirements under the model. Stay tuned on all of that. It's a very ambitious effort and involves a very significant number of primary care practices here in the state. a key role that the commission has taken on, staff has taken on with collaboration from the department is the formation of the advisory panel that will assist the department in providing input in enhancements and improvements in the program going forward. We're working with the health secretary and the program management office at MDH to develop the makeup of that advisory panel and hope to report to you in November on the status of that group.
Yes, Commissioner.
Could I request with regard to the primary care program and the care transformation organizations that we get in our updates just, at some regular level, like quarterly or every 6 months, a report on some metrics of performance for that program, the number of patients that are involved in the total cost of care for that population, how we're doing with managing total cost of care under that model.
We'll definitely, we're very interested in that, and how quickly that can be churned out is some question, but we'll definitely.
I definitely hope that it's going to be a year before we have a handle on it, but at some level, it will be good to see that, and particularly to see the level of engagement of the physician practices. There are two plans, two different levels in which they can participate. One involves they're receiving an upfront payment and then a routine level of payment on a per service basis, and then the other involves an enhanced upfront payment and a decreased level of services. The second model sort of implies a deeper level of engagement in the program and buy-in. And from our perspective, knowing the percentage in the two programs would help.
So we know, and it was reported at this I think someone has put us on hold, and we are now listening to some rather uninspiring crap that
I was actually rather excited.
So we think that based on what has been provided at a public meeting yesterday, that the vast majority, more than 90% of the practices are going to be in the lower track, and only a few are going to be in this enhanced track, which we have not heard of practices whether they're the first track is more cautious, the second track is more ambitious. The risk of loss is potentially greater in the second track. So stay tuned.
Okay. Commissioner Sargent. Yeah.
Thank you. Did you say 675 practices?
About 575.
75. One thing that in for Commissioner's policy, because they're looking at the license program, as you're ramping up before you have results, you might think about reporting on penetration. Is this set, like they have to be in now in order to be in next year, or will more practices be able to join that?
Well,
time goes on?
It was the commission is not directly the program manager. The commission staff advocated for a gradual ramp up, but the enthusiasm was such that it's estimated by some that 80% of primary care practices eligible to participate are in on the first year. So it's a very, it may rival the Care First participation level.
And some of those are using CTOs and some of those are not. I think it's up to the practice whether they do or not. Have they announced yet whether or not they are with CTOs or whether or not they're doing it themselves?
So I believe that we probably have that. We have a summary document I can send to all of you. But I believe about 60% of the practices selected what are called care transformation organizations. They typically are health systems, but they also can be large physician organized groups and some accountable care organization infrastructure have also agreed to be CTOs, but the bulk of the CTOs are health systems.
It's one thing, it may be hard to report, but one thing, an intermediate before you have results thing also might be what are the practices using the CTOs for? So like, there's a menu of things they can use them for, but in practice going forward, what are they actually would be, I think, interesting for people designing policies to understand.
Are there any further questions? Any of the center directors have any updates at all? Paul, you have the new staff member to introduce. Oh, yeah. Okay, Kevin. Yes. Okay. Oh. Okay. Welcome aboard, Mr. Baker. Okay. Commissioners, before we consider any other actions today, I want to remind you that if you feel that you may have a conflict of interest or an appearance of a conflict of interest and you need to recuse yourself, please do so. You should move out of this commission room into the conference room. And at the end of the disposition of the issue, then the staff will notify you and you can return. But please announce that you are going to do so. So for the record, we have a clarity on that, okay? All right. Our next item is a certificate of need issue. The Brenton Woods Health and Rehabilitation at Winfield. Brenton Woods Health and Rehabilitation has applied for a certificate of need to replace and relocate its existing facility. Kevin McDonald, Chief of Certificate of Need, will make the staff recommendation.
Thank you.
Yes.
Excuse me, before we get started, I'm going to recuse myself.
You have to recuse yourself. Have the record show that Commissioner Hafey recused herself. Thank you. Thank you, Commissioner.
Thank you, Chairman. Mr. Chairman, and good afternoon, Commissioners. Brenton Woods Health and Rehabilitation is applying to build a 60-bed replacement nursing home on the campus of Carroll Hospital in Westminster, approximately 20 minutes from its current location in Sykesville. The applicant is owned 55% by LifeBridge Health, and there are 5 other individuals holding the ownership of the remaining 45%. The facility is operated by Brenton Woods Management Company, LLC, that manages a number of nursing homes in the state. The facility was built in 1959 and does not comply with current safety codes in several parts of the facility. The proposed replacement facility would be 47,500 square feet. 35,000 square feet would be on the main floor and would contain all the rooms and patient treatment and activity areas. The lower level would hold support functions like the kitchen, laundry, and some administrative functions. There will be 40 private rooms and 10 double occupancy. This is a considerable increase on the private rooms from the current facility's 6. The cost of the facility is $14.8 million, estimated at $14.8 million, and the applicant plans to fund it with cash. The need for the project, this is not, obviously not a project to add capacity, but to replace a facility that is rapidly becoming obsolete. Thus, it would not change the supply-demand dynamic in the jurisdiction. Although the applicant did express its belief that the project might help stem what it sees as a disproportionate outflow from Carroll County to other jurisdictions to receive nursing home care. And for example, the applicant compared the residency of the Carroll, that 72% of Carroll County
residents that need nursing home care are served within that county as compared to 80% in the neighboring county of Frederick. And they picked Frederick because it is a county in which the supply and demand is pretty well matched. In terms of looking at alternatives, the applicant did a thorough job of looking at maintaining the current facility as well as renovating and expanding it, and concluded that it would not really be a feasible thing to do in that it wouldn't address the private room issue. Would be difficult to deal with all of the life safety issues. In addition, the new site is going to be much more accessible to residents who need hospital care or medical visitations, being right on the campus as opposed to about 12 miles away, right on the campus of the hospital. In terms of looking at whether, since this jurisdiction has an occupancy that is slightly lower than the statewide average, one of the alternatives that might have been considered would be, well, should we just allow this nursing home to close up and have the remaining facilities absorb that demand? But as pointed out in the staff report, 30% of the jurisdiction's facilities holding 41% of its beds had a 1 or 2 star overall rating in the most recent CMS report. So that capacity might be somewhat lacking. In terms of viability and financial feasibility, audited statements show that LifeBridge does have the resources to fund this project. As far as ongoing operations, while the applicant's assumption regarding the proportion of Medicare days might be a little optimistic, as is its projection that it would not be adding staff to support a slightly higher acuity rate that would bring. Despite the fact that those might be a little bit optimistic assumptions, staff concludes that the applicant's projection of a modest positive operating margin is reasonable. It was not projected to be any impact on existing providers. This is already there. This facility is already there. It's not an addition of capacity. The staff concludes that the proposed project complies with the applicable standards in the state health plan as well as the review criteria, and recommends approval with our 2 standard nursing home conditions relating to a member of Britton Woods signing a memorandum of understanding agreeing to maintain at least the minimum proportion of Medicaid patient days, and secondly, that they then go ahead and meet and maintain that minimum proportion. With us today is Darren Cortese, the president of Britton Woods, Teresa Fletcher, assistant vice president for business development for LifeBridge Health Partners, Chris Coleman, the assistant vice president for finance of Carroll Hospital, Maurice Spielman, director design and construction management for LifeBridge Health, and Marta Harding, the legal counsel.
Okay. Welcome all. Thank you very much for showing. Any questions for Mr. McDonald? Yes, Commissioner Reimer.
Yeah, just a quick question. What's the relationship with the hospital?
The relationship,
With the hospital, the Carroll County Hospital?
they are both part of the LifeBridge system. Beyond that, I can't speak to what the relationship might be. Perhaps the applicant could.
So is there an impact on is a positive impact on the hospital? Is there looking at some benefits financially for the hospital? Discharging patients earlier, reduced length of stay, that kind of thing. Is that?
Yeah. Could you come up and answer the question clearly so that for purposes of the record, we can have a clear record. Thank you very much.
That was one of the things that we looked at in terms of reducing the delays between discharge. Because sometimes it could be a day, it could be 2 days before you can get a placement, like in a nursing home. And we're hoping by having a system and, within EMR, a lot of times it's the EMR that will go through and copying records and that kind of thing. I think that's a big piece of it. And this could happen in the old facilities, We don't know. We're now. We'll figure that out. That's a good question, though.
Commissioner Sargent.
I was struck with the staffing question. I was involved years ago now with dealing with continuing care facilities in need of renovations. And I think we had looked at we were going to have to rebuild, and there were actually less staff that you needed because it was a better designed facility. I don't know if that's what you have gone.
Sir, please identify yourself with
Hi, I'm Darren Cortez, the president of Britton Woods.
Yes.
Actually, our projections did call for a slight increase in staff, but mainly because of the acuity we were expecting being so close to the hospital.
Right.
So we didn't build any operational efficiencies or anything like that into the staffing pattern.
Okay. Any further questions? Yes, Commissioner Tamarkin.
And this might be more towards our staff. So when looking at the need for patient beds, according to the chart, it says that Carroll County is over by 181, too many beds. But on the other side, it's also saying that the population of 65 and over is 50%, projected to be 50%. So that would lead one to believe that there's more of a need. So how are you balancing all of this out?
Certainly the elderly population being higher than the state average is a factor to consider. On the other hand, that is built into the nursing home projection formula. So in a way, it's worth giving you that information, but it actually is baked into the formula as well.
Do you feel they need as many beds as they're building?
Do I feel what?
Do you think they need that many beds?
This is an existing facility, so we treat that differently than we would treat a new applicant. A new applicant could not apply at this point.
And do we do that only for nursing homes, or is that overall?
I can't really. If we had a hospital that was looking to replace itself with a state health plan that said beds weren't needed, I think that need would have to be proven. I don't think it would be an automatic acceptance.
Okay, thank you.
Okay, Commissioner Pollack.
So I want to just congratulate LifeBridge on this. I think this is, the type of thing that we need to see more often. It's exactly the right move, and it's the way you develop better care. But I think it's important to highlight that it does this on two ends of the spectrum. So when you're operating a hospital, one of the big challenges that we have is getting patients out the back door. Having a skilled nursing facility right on ground facilitates that dramatically, and that opens up access to care for patients who need it. It makes it easier for ambulances to get patients to the hospital. Makes it easier for doctors to get patients into the hospital. There's a whole lot to improve access to care and improve the quality of the care. On the back end, by having the facility that close, and you pointed out much of this in your application very nicely. On the back end, what it does is it allows the patients in the facility to have access to the resources of the hospital on the same ground, which decreases readmissions without question, or should decrease readmissions. This is the total package decreases total cost of care. It's exactly the direction we want to go. The point of saying all this is that under our state health plan right now, if there wasn't a bed need and somebody were trying to add beds to do this, you would have a hard time doing it. And I think we ought to start thinking about ways to relax the CON process so that the bed need projection is not a rate limiting step in building similar facilities and similar models, because this is exactly what we need in order to be able to, as a state, meet the total cost of care requirements under the new contract.
Any further questions? No further questions. Thank you very much, Mr. Cortez. The motion then is to approve a certificate of need for Britton Woods Health. Do I have a motion to approve? A motion and a second. Any further discussion? Okay. All those in favor of the motion to approve the certificate of need application, say aye.
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 Opposed?
Aye.
Okay. Any opposed? Very good. Thank you very much. Congratulations to Britton Woods. You have your certificate of need. Next item is a certificate of need. The University of Maryland, St. Joseph's Medical Center has applied for a certificate of need to replace and consolidate its current perioperative services facility. Mr. McDonald will present the staff recommendation. Commissioner Pollack is recognized.
I'd like to recuse myself in this matter.
Okay. Have the record show that Commissioner Pollack is recused.
Okay, thank you. This project would modernize and consolidate outdated surgical and cardiac cath facilities to enhance efficiency. These functions are being carried out now in two separate areas on the ground floor of the hospital, requiring duplication of several related functions, which will be able to be consolidated into one. In addition, the operating rooms average about 27 years in age, and most of them are under today's standard of 600 square feet. The project will actually reduce capacity. The number of ORs in operation will decline from 17 to 16 after the project. There will also be fewer cardiac cath labs. It's going from 5 to 2, and a reduction in cardiac care unit beds from 9 to 6. Total project cost is estimated to be about 60 million. It's going to be funded with 40 million in cash and 20 million in fundraising. The applicant is not seeking an increase in its GBR to cover project costs. Actually, since the applicant is not requesting any GBR adjustment to cover interest and depreciation expense for the project, and since it's not adding beds, ORs, or new services, it could have avoided CON by what we call taking the pledge, which is a part of the CON regs that allows an applicant who says they will not take more than not ask for more than 1.5 million in payment to reimburse for the project over the life of the project, allows them to then avoid the CON process. The applicant chose not to in this case. That does leave open a future avenue for appealing for that kind of funding, but they're not doing that at the outset. Looking at some of the high points against the standards and criteria, the project will significantly increase efficiency, reduce expenses for maintaining unnecessary OR capacity, preoperative and post-anesthesia care areas, lab space that is unnecessarily duplicative because of the separation of some of these functions. Project is expected to result in the reduction of close to 21 FTEs, which translates to a savings of about $2 million annually. In terms of looking at need, again, this is not a capacity-based need case. It's needing to become more efficient and to modernize. In terms of viability and financial feasibility, the resources are available through the UMS system, and staff judged the utilization, revenue, and expense projections to be reasonable. The financial projections show a continuing margin, positive margin, consistent with recent financial performance. Because this is essentially a project that is just replacing existing capacity, there's not expected to be impact on other providers, and thus the staff recommends approval of the project based on its compliance with the applicable state health plan standards and other applicable CON criteria. There is one condition we would recommend attaching, and that is that any rate increase proposed by the hospital related to the capital cost of the project shall not include the amount of the projected construction cost for the space that exceeds the per bed square footage limitation in our health plan standards for those portions of the contingency allowance, inflation allowance, and capitalized construction interest expenditure that are based on the excess space. Translating that for you, there is a standard in the acute care chapter that limits the reimbursable space for a nursing unit to 500 square feet per bed. This would be about 523 per bed. So that excess would not be reimbursable should the applicant ever choose to go to HSCRC looking for an increase in its GBR related to this project.
And that's a permanent.
At this point,
Do I understand that correctly? It's permanent? In other words, forever.
well,
If there's any,
if they chose in the future to come and appeal this GBR based on this project,
okay,
I think there are 6 beds at 23 square feet per bed. So whatever proportion that would have been, which is minuscule,
right,
would not be
reimbursed.
allowable to
Right,
be
okay,
reimbursed,
right.
which is a moot point at this point since they're not asking for that anyway.
Okay,
In attendance for St. Joe's is Thomas Smythe, Dr. Thomas Smythe, President and CEO, Walt Furlong, the VP for Strategy and Business Development, Paul Nicholson, Senior Vice President and CFO, Craig Carmichael, Senior Vice President for Operations, Matthew McGovern, who's the program manager. They also have consultants here, Craig Wheelis, who is Director for Healthcare Business Planning Services for KPMG, Andy Solberg, and legal counsel Thomas Dame and Mallory Regenbogen.
welcome all to the commission. Okay. Thank you very much, Mr. McDonald. I should note for the record that Commissioner Hafey will also be recused, has recused herself for consideration of this action. Okay, we have a request for approval of a certificate of need for the University of Maryland, St. Joseph's Medical Center. Do I have a motion to approve? Motion, do I have a second? A second? Yes, second, okay. Any questions?
I did have,
Yes, go ahead.
go ahead.
$1 million, about a third of the project from philanthropy. Is there a business plan, likely cost? $20 million is a lot for building.
Folks on the phone can't hear anything she's saying.
Pardon?
It was difficult to hear.
Oh, sorry. No, I'm curious on the $20 million from philanthropy. Is there a business plan, likely prospects for it? Because if they're reserving the right to go back and just the global budget, would it have anything to do with not being able to raise the money from philanthropy?
Staff did ask that question, and the applicant, if I recall, spoke to the system-wide resources and system-wide efforts at philanthropy. But again, I think that would be something best answered by the applicant.
Good afternoon. My name is Mallory Regenbogen. And so far, the applicant has a campaign in place specific to this project with a goal of raising around $20 million. As of March, they had already raised a total of $12 million. And they also have a very strong track record in fundraising in general. I think in the past 10 years, they've raised a total of $43 million in other campaigns. They're very confident that they'll be able to raise these funds. That's right. Thank you.
Thank you very much. Commissioner Sargent.
Thank you. So Kevin, I might put you on the spot a little bit because this looks like a fine project. The one thing we didn't actually evaluate is need, right? Because they're replacing adding? It seems like in this case we built an exemption that people aren't using because they would like to preserve the rate issue, which is not an MHCC issue. And I'm wondering about the structure we've chosen, if we should even be in this business, if whether the HSCRC wants to include a project in its rates at some point down the road belongs in our process at all. Like whether maybe we should have an exemption. If we're not changing the beds, if the HSCRC wants to do an evaluation 10 years from now to see if it was a worthwhile project for including in the global budget. Are we adding anything of value? Like I said, I'm putting you on the spot a little bit because we are looking at the CON process and reform, so this does relate to that.
You know, I don't want to give the impression we didn't look at need.
And I'm sorry, I don't mean that to sound like
we did evaluate the number of rooms they were asking for compared to the formulas in our state health plan, and they were well within that. And your question is more
I'm not intending that it's stated as a criticism. You had to look at every one of the factors that we allowed for you to look at. It's really more about the process.
So you're asking more of a, I guess, philosophical question about
right about
what the work group is doing now.
If we've created an exemption that folks aren't using, and they're not using it solely because of what they want from treatment in the future from the HSCRC, and it doesn't really have to do with the need and the things we look at. The question is, what is our agency? How is our role being fulfilled with this analysis? Because I think we're grappling with whether part of it is whether or not that ought to be something HSCRC should look at when it's setting global budgets, maybe, but they wouldn't come here at all. They just take the exemption.
You know, I think you know, probably within the commission's purview when you look at the task force report would be to take a position on something like this, you know, such as saying that I don't know if mandating the applicant to avoid the CON process when they're in a situation like that, rather than trying to hold it in their back pocket as a future insurance policy. We've had several projects like that. The Calvert project we had a couple of years ago similarly was not asking for a GBR, but they wanted to have the future flexibility to do so.
And to be fair, I can understand why a hospital would want the flexibility. If we're going to require them to do it now or never, it's going to be hard to not want to preserve that. So I'm also not being critical of the hospital. I'm wondering if we should look at one thing we should look at.
Mr. Director, you have an option.
So I think it's important to note that areas where there have been consensus in the CON task forces, generally providers have endorsed raising or eliminating the capital expenditure threshold, which is currently under Maryland MHCC statute and regulations, the trigger for requiring CON. I would add and qualify that the hospital proposals have been for relaxing it, not eliminating it. And the $60 million threshold, I think that would, the $60 million budget that has been reported for this particular estimate project is still above the threshold that some of the stakeholders in the hospital community have recommended. So it might still, if we were to follow MHA and other guidance, might still trigger a CON. But obviously we have not acted on any recommendations, but clearly projects that don't cover any categorical requirement but are triggered because of a capital expenditure trigger are definitely areas that we ought to look at carefully as to whether they should be covered within the scope of CON in the future.
Okay. Any further questions? Yes, Commissioner Reimer.
Sure, just a quick question on, I was just looking at the surgical volumes, and obviously there's a decline. And again, I apologize, I just got the packet today, so I'm kind of reading through my information here. So I see a 15.5% decline in inpatient surgical volumes, with a projection of increase in outpatient volumes. So I assume this is all regulated services in the hospital, whether it's inpatient or outpatient. Is that correct? Okay. So there's no, I mean, all this will continue. So we're seeing an increase. I just find it hard to believe over time that we're going to see outpatient volumes in a regulated setting. I would think that some of those outpatient volumes, unless they're fairly high intense outpatient volumes, being more done in a surgical type center outside the hospital rate setting. So that was my only comment there. We're seeing a decline in inpatient volumes, but they're seeing a significant increase in outpatient volumes. So I just look at this, the capacity of those ORs.
Their projections did, they did decrease their projections by an assumption that a fairly significant amount of that volume would be going to ambulatory surgery centers, and that the remaining outpatient volume that they would be getting would be of a higher intensity. The total number of rooms that they, I mean, right now they're operating 17 rooms. I think they are licensed for 21. There are several of them out of commission right now that they're not proposing to put back into use with this project, based on the trends that they've looked at in terms of the preference for outpatient facilities, patient preference as well as payers' insistence on outpatient.
I just find it, interesting going forward on their volume projections that they have a high number of outpatient cases that are going to increase over time. And I would think that would see decline in outpatient volumes in the hospital. So I'm making that observation because realistically, I don't know if that's really going to happen. So, I mean, I think these ORs may see decreased capacity over time as opposed to maintaining capacity. Again, I don't know if everybody wants to comment on that, but that's what I, based on what I'm seeing here. Again, just reading it today, but I think that there could be some, they're looking at their volumes here, projected surgical cases going up 10,293 from 9,300 up to 2025. Is that realistically going to happen in a hospital setting?
Yeah, I think part of that increase is based on an increasing population. So a lot of factors that they were juggling in those projections.
Any further questions? Any further questions at all? Okay, we have a motion. We have a second to the motion. So the action then is on the approval of a certificate of need for the University of Maryland St. Joseph's Medical Center. All those in favor of the motion say aye.
Aye.
Aye. Any opposed? Okay, very good. Thank you very much. University of Maryland, you have your certificate of need. Yes.
We confirm the number of ayes we have on the phone.
Yes, let's do that right now. On the phone, how many ayes do we have?
Commissioner Metz, aye. Commissioner Trump, aye. Commissioner Trump, aye.
Okay, so we have three. Okay, very good. Excellent.
Well, you may have more than three. Oh, yeah, three.
Four. Okay.
Four.
Excellent. Thank you. Thank you very much.
Commissioner Moffitt, may I ask for just a moment for Dr.
Yes, please do. Dr. Smythe, we're happy to have you here. Yeah, come up to the microphone so you can be heard for the record.
Good afternoon, everyone. Thank you for having us here today. And I just want to thank the commission staff for their hard work and for you for considering this project. We really appreciate it. This project will allow us to dramatically modernize our operating rooms to provide even safer care than we provide today, high quality, modernized care with a lot of technology. And I also just want to publicly thank the individuals and the organizations within our community who have led support for us. So thank you for allowing me this opportunity for us.
Well, Dr. Smythe, we're very happy to have you here, and we're going to do everything we can to help the providers of the state of Maryland do what they can, provide the highest quality care, because that's our job. To the extent that we can fulfill that responsibility, that's what we want to do.
Thank you very much.
Thank you very much,
Appreciate it.
Doctor. Okay, the next item is an exemption of from certificate of need for the merger and consolidation of Adventist Behavioral Health. Commissioners, Washington Adventist Health and Shady Grove Medical Center are requesting a consolidation of 16 of the 26 adult acute psychiatric beds now in operation at the Washington Adventist Hospital in Tacoma Park. They want to consolidate that with psychiatric facilities at Shady Grove Medical Center in Rockville. Mr. McDonald will present the staff recommendation.
Thank you.
Mr. McDonald? Yes.
Thank you. You might think this is a rerun of some previous meetings, but it's not exactly. It's the third piece in the puzzle.
Kind of a serial.
Yes,
Right. Stay tuned for next week. Okay.
I think this is the last
Next
episode.
one. Oh, okay.
Last
All right.
episode.
Okay. Last episode.
In recent months, the Commission has taken action on two related requests from Adventists. One was acting on an exemption to merge the 117 psychiatric beds at the former Adventist Behavioral Health Rockville facility into Shady Grove Medical Center. I think that was back in May. And then just last month, approving a project change to the hospital replacement, the Washington Adventist Hospital replacement project that was approved in 2015, approving a project change to relocate 10 of the psychiatric beds at the existing Washington Adventist Hospital into the replacement hospital in White Oak. And then this proposal would take the remaining 17 beds that are at the current Washington Adventist Hospital and merge them into Shady Grove. And none of this happens until that hospital is built and ready, and then all these changes take place. Our regulations permit an exemption from CON for the merger or consolidation of two or more hospitals or healthcare facilities if the facilities are part of a merged asset system. And Shady Grove and Washington Adventist Hospital are part of Adventist Health, so they fit that criteria. Adventist estimates that the cost of adding these 16 beds to Shady Grove would be about $3.4 million for renovation and furnishing a space that already exists in that building. The funding would be cash from the Shady Grove Medical Center operating budget. On an annual operating basis, it would add about $4.4 million to Shady Grove's expense and shift approximately $5.3 million from Washington Adventist Hospital's GBR to Shady Grove, leaving a net positive impact of close to $900,000. In order to give this exemption, the Commission needs to be able to find that it is in the public interest, that it is not inconsistent with the state health plan, and that it will result in more efficient and effective delivery of health services. Staff's analysis concludes that the initiative would strengthen and ensure the continued viability of Adventist Health behavioral health services. Consolidating these beds also allows patients to have access to specialized programming that would not be possible in a smaller facility. Staff found the project to be not inconsistent with any portion of the state health plan and believes that it will result in the delivery of more efficient and effective healthcare services by enhancing operational and clinical efficiencies and benefit patients, again, with access to specialized services that they would not have without this consolidation. Thus, staff concludes that the requested consolidation is in the public interest, is not inconsistent with any provisions of the Psychiatric Services chapter of the State Health Plan, and that it will result in more efficient and effective delivery of health services. And here to represent Adventist for this project is Robert Jepson, Vice President for Business Development for Washington Adventist Hospital, and Marcel Wright, Vice President of Behavioral Health Services at Shady Grove, as well as their attorney, Howard Solins.
welcome home. Okay. Commissioners, are there any questions for Mr. McDonald? Commissioner Sargent.
I had a question, but also take some guidance from the executive director as to whether it's one that anyone feels like they can answer. I would be interested in knowing the cost for applying and going through the exemption process in comparison to what it would have cost to have the CON. And I'm sort of hesitating on how to introduce that, because I'm not sure anybody in the room is competent to talk to that, but I put it out there in case somebody does want to. Okay. How's that?
That's a very, very good
Still a
question.
little nervous coming up to answer that question, but I sort of,
It's all right.
Kevin went back at me. For the record, Robert Jepson with Adventist Healthcare. I think to answer your question, I can't really compare it because we didn't file a CON on this particular thing, but I would say I think it's less complex to go through the exemption. And we felt we were on pretty solid ground because our organization is all in the same jurisdiction. And so we felt like we followed it to a T, so we didn't feel like there was going to be a heavy lift to convince the commission that from a regulatory standpoint would fit that bill. But in sum, to answer your question, yes, I think it was a simpler and smoother process than normal, just because the regulations are different. There's certain things that are required of a CON by both the commission and the applicant that are not required of the commission and the applicant in an exemption process. And if I could just add one thing, that we do appreciate the commission's support on this and want to acknowledge Ms. McDonald and Mr. Chan. This really is the culmination, I think, as was explained by Kevin pretty well. We're trying to preserve and stabilize behavioral health services in Montgomery County. Behavioral health services are kind of a fragile aspect of the healthcare system. And by knitting these services to the acute care hospitals, it does several things. One, it puts them on a stable and predictable revenue model through the GBR. The other thing is there's operational efficiencies to be gained by blending them to an acute care facility. A fair number of admissions come from the acute care facility, so operationally, programmatically, and financially, we felt this was important to do to really set these services up for long-term stability.
Okay. Any further questions? Commissioner Tamarkio.
In this case, the 16 beds that are being transferred would be transferred when Washington Adventist completes its new facility and opens in White Oak. So the beds will continue to operate in Tacoma Park while the acute care hospital is there. And then when that acute care hospital moves to White Oak, those 16 beds will transfer up to Shady Grove Medical Center. Does that answer your question? Was your question related to the services in Rockville, or?
I'm not familiar with the geographics.
Okay.
Really.
So okay. So Washington Adventist is about 18 miles in the southeastern part of Montgomery County. Shady Grove Medical Center is in Rockville, in about the central part of the county. So it's within the same jurisdiction, about 18 miles apart.
Okay.
And I would note parenthetically that previously the commission approved the transfer of 10 psychiatric beds from Tacoma Park to White Oak, which allows us, which was not in the original CON, but that addendum allows us to continue providing psychiatric services at that new hospital.
Thank you.
Okay. Okay. Any further questions at all? Okay. Okay. Do I have a motion to approve the CON? Commissioner Boyle, Mr. Pollock, second motion. Any further discussion on the motion? Okay. No further discussion. All those who are in favor of the motion to approve the exemption, say aye.
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 Any further? Any
Aye.
opposed? Anybody opposed? Okay, very good. All right, we've got it. Okay, congratulations, Mr. Jepson. You have your CON. Exemption, rather, I should say. There you go.
So
Yeah.
I think it was appropriate that Commissioner Sargent asked Mr. Jepson the cost. One of the things that we've looked at as Adventists has come forward with, enhancing the delivery of healthcare services in Montgomery County has been, they've used virtually all the vehicles that we have available to us, including CON, modification of CON, and exemption from CON. We do look at all of those carefully, and it's not simply a matter of trying to let someone out of something, but we generally direct applicants into the appropriate regulatory tools that we have at our disposal. So I think Adventists can talk about the various expenses of various tools probably better than anyone as we've gone through this process over the last year. Absolutely.
Thank you. Thank you very much. Okay, the next item is something that's not controversial at all. It's the maintenance of certification work group study. The maintenance of certification work group met 5 times. The study issues related to physician maintenance of certification requirements and studied the interaction between these requirements and payer and hospital credentialing rules and requirements. Megan Renfrew, the Government Relations and Special Projects Director, will discuss the recommendations and ask for approval to submit a response to the chair of the House Health and Government Operations Committee. Megan, the floor is yours.
Okay.
Okay.
So just to back up a little bit and lay some background, particularly for those in the audience, because I know I've talked to all of you about this before. In the spring of this year, in the last legislative session, Chairwoman Pendergrass sent us a letter requesting that we bring key stakeholders together to study physician maintenance of certification and related concerns. This letter was a response to legislation that was introduced in the last session and then withdrawn. And so we convened a work group of physicians, hospitals, national board certification entities, insurers, and the Maryland Board of Physicians, HSCRC, and MHCC staff. The work group met 5 times, as the chair noted, over the summer and the fall, and today I'm presenting you with a draft letter for your review. To provide some context, board certification is a non-governmental credential that's granted by national boards of specialty physicians. So there's a board for each specialty. And that these entities are normally structured as nonprofit organizations and then grouped together in larger organizations. Board certification, just to be clear, is distinct from state licensure and is not required for state licensure. So I just want to make sure we're clear on that. Starting in the 1970s for some physician specialties and accelerating after the Institute of Medicine issued their famous To Err is Human report on patient safety, specialty boards have increasingly required periodic recertification processes for people who come into their board after the recertification process is developed. Some physicians have raised concerns about these national recertification programs. The concerns include fairness, time burden and access to care, relevancy, expense, quality, and issues related to market choice. With respect to fairness, newer physicians see it as being unfair that they're subject to the recertification requirements, while older physicians are what's called grandfathered and do not have those requirements. For time burden and patient access, participating in the recertification or maintenance of certification requirements takes time, and that means it's time away from a physician's practice or family, and that limits things like patient appointment slots, and so that limits access to care. For relevancy, some physicians feel that the exams and other requirements contain material that's not relevant to their practice, and also that performance on an exam is not a good measure of whether someone is a good physician necessarily, that that's not the skills that make you good at the bedside. There's also expenses related to the exams and recertification fees. There's also some discussion about the opportunity costs of, again, being away from your practice or from revenue earning activity when you're engaging in recertification activities. There's also a fair amount of debate about the connection between recertification and quality. This was debated very enthusiastically in our work group, and also is debated in the literature, whether recertification results in better quality of patient care or whether that's not proven. And then finally, with respect to market choice, there is an organization that is quite large and that offers board certification, and so some physicians felt like they didn't have enough choices about where to go for their board certification, and that the large organization wasn't being responsive enough to their concerns. So that's describing the concerns. Board certification is technically voluntary. However, it is required by some hospitals as part of their credentialing. That means that many physicians feel pressure to maintain their board certification to maintain their employment or privileges. We did find that board certification is not a requirement for credentialing for most Maryland insurers, although Kaiser Permanente is an exception because they have an employed model, so that they're also a provider. Insurers do regularly delegate credentialing to hospitals, which means they then sort of end up passing through the hospital credentialing requirements. So the work group clarified a number of questions that were raised in the legislative hearing last year and in the work group discussions. For example, a key question in the legislative hearing last spring was how a statutory change related to this issue at the state level might affect hospitals' accreditation with the Joint Commission. We learned that the Joint Commission strongly prefers that hospitals not be restricted in setting their own rules for credentialing, but that accredited entities have to conform with state law. And that means that if the state law did have some rules related to these issues, then the Joint Commission would not withhold accreditation due to an entity's compliance with the state law. The work group also researched and discussed state statutes in other states that are related to the use of recertification requirements by hospitals and insurers. There are 5 states that currently have statutes on those issues. In general, we found that those statutes were too recent to offer clear data on impact or lessons learned for implementation that we could apply in Maryland. We also talked about mechanisms that would allow for some change with no state statutory changes. So, for example, the largest national specialty boards are currently reevaluating and changing their recertification requirements and processes. That is ongoing, and for the largest board, I think there'll be more to come in the next year or two. In addition, some physicians have created a new national certifying board called the National Board of Physicians and Surgeons to provide an alternative to the traditional national specialty boards. This newer organization has less burdensome recertification requirements than existing organizations. In addition, hospitals may choose to change their credentialing requirements through changes in their medical staff bylaws. One hospital in the state has made changes to reduce recertification burden on their physicians, and this hospital has had no issues with their Joint Commission accreditation. Finally, the Maryland Board of Physicians, while they do not use board certification for licensure, they do recognize national certification entities for other purposes. And current Maryland law allows specialty boards to apply to the Maryland Board of Physicians for recognition if they are not currently recognized.
After careful consideration and discussion, the work group was not able to reach consensus on a legislative solution. So that is the conclusion of the letter. A draft letter has been provided for your review. When I presented on this topic earlier in the summer, we discussed concerns about overall burden on physicians, and I tried to capture that concern in this letter, even though we didn't come to a clear point of recommendation. So at this point, I'd welcome your questions or comments.
Okay. Thank you very much, Megan. And I know that talking with physicians myself, I know how controversial this issue is. So anyway, commissioners, do you have any questions? Yes, Dr. Pollack.
So thank you for an exhaustive review, and I think you hit most of the issues that are out there with regard to this. If you ask 5 physicians about their opinion with regard to board certification and the recertification process, you'll get 10 different answers as to what the problem is. But right now, as you pointed out, this isn't regulated by the state,
right,
at all, and it's the question I think is buried in the letter is that you said you weren't able to come up with a consensus regarding a need for legislative intervention. But that's the same as saying you've defined no need for legislative intervention at this point. And I think that's buried in the letter. I'd like to say that up front. We have defined no need for legislative intervention. Well, no. A consensus means you defined a need. Without, you either defined it or you haven't defined it. So there is no need that you've defined, right? I just don't want this thing coming back. We're not currently regulating it. Nobody's defined to me a compelling patient care need, an imminent patient safety problem. We're not trying to extend this discussion further and study it further and come back a year later and do this again. We're trying to, either we found a compelling need for additional legislation to intervene or we didn't. That's the question we were asked. And we don't have consensus suggests we got to go study this some more.
I think the language you're seeing is a delicate walk between the many stakeholders at the table. And so if you want to direct me to do something different, certainly.
I would propose that we do something different. I would propose that we answer the question. No, there is no compelling need for it. And I think it's a yes/no kind of thing, right? The burden was to demonstrate a need, and we failed to meet that burden.
Is there any, this is important, among Dr. Pollack has basically made a proposed change to the substance of the letter. Not the content, basically, but the presentation is, it basically what Dr. Pollack wants us to recognize is Aristotle's principle of non-contradiction. Something either is or it isn't. Either there is a need or there is not. And that seems to be a reasonable thing to do on planet Earth. So, I really invite members of the commission, if there's a disagreement with Dr. Pollack, if you have a better interpretation of the data here, I'd like to know it.
I guess my reaction to it would be not so much disagreement on the substance, but I didn't read this in mind with whether the MATC was taking a position or whether there should or shouldn't be legislation. And I'm not sure if we knew that was the outcome, we wouldn't go back and look at it with different eyes. But I might suggest we amend it because where we say we didn't reach consensus on a legislative approach, kind of pre-assumes that there should be a legislative approach. So as maybe a less controversial, there wasn't consensus on whether there should be legislative action and what that action would be. Might be a sort of rephrasing that somewhat. We still aren't drawing a conclusion, but we're making it clear that we're not finding that there should be action in the first place.
We're not finding that there should be legislative action. Okay. I think that's a tamer way to say the same thing. I'm happy to do that.
A tamer way from Dr. Pollack. Write that down. Well, no, the opposition's got to be here.
I'm thinking maybe that we're just clarifying what they meant.
I think that this particular study request was we were asked not to take a position necessarily to serve as a referee on an issue that the legislature couldn't reach consensus on. And I think we can probably characterize it pretty well. I think that we could add our own spirit of the commission. It almost strikes me as it needs to be another letter, that we spent a lot of time balancing perspectives of the stakeholders, emphasizing our role as referee, as Chairman Pendergrass requested us to do, but not necessarily staking out a strong position ourselves. And if the commission feels as though we want to say there's no, we don't believe there's need, I think we say that in a separate communication rather than, because I don't really want to go back to the resurrect this and engage in any further discussion after we largely worked hard to foster a compromise document. So I think it would be fine if the commission provided their position on it, but we keep this letter intact. And I think
Who's this letter signed by?
it's signed by me, but it is you know, the reporting out to the chair of the results of the work group. So I think it's normally we definitely encourage, you know, the commission to weigh in on this, but I think we saw our role here as very circumscribed. It's just simply bringing people together.
How about we add a paragraph or a sentence at the end that just says that based on review of the work group's findings, the commission, the language that Commissioner Sargent had that was much tamer, I think was it.
And then I guess I'd touch you a little bit, because the sentence at the front that says the members of the work group are not able to reach consensus on a legislative approach. We're not saying on whether there's a need for a legislative approach and what that approach would be. Is that not still accurate of what happened at the work group? Because it seems to me in here that not everybody that came in was say the legislature needs to act and just can't agree how. So I thought it seemed like it was clarifying what happened as opposed to going off in a different direction. Right. I suspect both was discussed. Should the legislature
Yeah, I mean, I think
doing anything, and if so, what?
I think there's certainly some stakeholders who feel there's probably a need,
Right.
or feel there is a need, and some stakeholders who
Can you
don't. So,
explain why people believe there's a need for a legislative approach here? We haven't heard that yet.
I'm not sure what originally what the study was supposed to do, what we were asking for a change to do.
There's a letter in your packet from Chairwoman Pendergrass, but probably what I also should have included, although that gets very complicated very quickly because it was withdrawn, but there was a draft bill in the legislature last session that looked to prevent use of maintenance of certification in, and I am doing this off memory, so, because I didn't bring that with me, but for hospital credentialing, for reimbursement and network decisions by insurers, things of that nature. And so that bill failed at committee, and we were asked through this letter then as a result to bring everybody together and facilitate conversation and sort of flesh out what the problem was and what the potential solutions were. So I think this, and there are a number of different stakeholders with strong views, so on various positions. And so I think Ben was right in characterizing us as a referee. So we did our best to flesh out the facts, to get actually quite into the details on those things. There's additional documentation on the work group's website, including a fairly detailed memo about what other states have done. And so the end result being this letter, which the work group has reviewed twice, and and had some fairly extensive debate on wording.
Okay. Commissioner Tamarkio, please.
So, in your view, having sat through the multiple meetings, was there consensus, or more than consensus, with all the stakeholders that this is a problem for the state of Maryland? Or was there a significant point of view that this really isn't a problem and everything's fine?
I think generally everyone is concerned about physician burden and physician burnout, right? Whether we're talking about quality or we're talking about this or we're talking about anything else. I think the question is when you get to the state of Maryland, right? So these are national boards and national processes, all non-governmental in nature, and then obviously Maryland hospitals and Maryland insurers. But and we, because of what our charge was, I don't think we asked that question directly. So I don't have a way to speak to what is consensus or not consensus on that particular question. I don't know, Ben, you want to step in?
So something that was just focused on what are the tools that could solve a problem, not acknowledging that there's a problem in the first place.
I think everyone acknowledged that there was a problem. I would say that. Yeah. Right.
Yeah. We're not even asked to be the regulatory body.
One at a time.
The Board
Go
of
ahead.
Physicians
One at a
is.
time.
Go ahead. Yeah, sorry. The Board of Physicians is the regulatory body. We're just asked for an opinion here regarding whether or not legislation is necessary right now to address this problem. It's not whether there's a problem or not. It's whether there's a legislative solution that's necessary. And my point is, as I made before, that if you can't define that a legislative solution is necessary, then you have defined that it is not necessary right now. And you can't equivocate on that answer. And just because there's no legislative solution to the problem doesn't mean a problem doesn't exist.
Right.
Not every problem is solved with legislation.
I'm sure, I don't understand what the problem is. What is the problem that we're trying to solve through legislation?
The problem is that national boards require physicians to recertify right now. And in order to maintain board certification, you have to submit to study, you have to submit to demonstrating that you're going through continuing medical education, and you have to take a quiz every 10 years and pass it. And the public demands that the public through these bodies has demanded some level of accountability to physicians for ongoing certification. Some physicians have balked that that's too hard to do every 10 years. And they're right. It's not always relevant to their practice. Doesn't demonstrate increase in quality necessarily, but it'd be very hard to demonstrate increased quality through that. And, you know, some people like me would say, so what? The public demands that you show something that shows that you're competent on an ongoing basis, so do it. And it's expensive. The state doesn't regulate that process at all right now. It's done through national boards. The Board of Physicians doesn't regulate that at all. It's done at the hospital level. And what some physicians want is for the state to intervene now, where they haven't intervened in this at all in the past, and say, hospitals, you're not allowed to use maintenance certification in deciding whether or not physicians should be credentialed. And my point is that that's not the role of the state to decide. That's the role of the free market to decide, if you will. It's doing a fine job of it right now, and there is no need for legislative intervention.
Okay, we've got to come to a conclusion on this. Mr. Director.
No, I think, you know, I don't think I can add too much more. I think, you know, the proponents of action would argue that they stand squarely behind, you know, practitioner, physician choice, and they brought this forward because they wanted an alternative board to choose from. They would contend they didn't oppose maintenance of certification, but they favored alternative methods. You can take that as you will. We looked at the nascent board, and we all reached differing conclusions about the rigor of that process, but recognize that the word there is it's a nascent developing board and trying to develop standards. But I think that's where we came out that there's no compromise is possible. I think the hope of the proponents was that the state would weigh in and give them a equal footing with ABMS in the maintenance and certification arena. We found no basis for any compromise solution, and doing nothing leaves the status quo, which is the free market drives it.
Listen, I want to, I think, first of all, I think the feeling here, at least, is the general feeling of the commission, unless I really misunderstand things, which is very possible, is that the commission is not happy with the idea of a legislative solution to this problem.
Right.
And it's better to state it up front rather
Okay.
than not. So, however, we don't want to confuse matters, right?
Yeah.
So maybe the thing to do is to, next to the last paragraph, just specify, where you have the language saying that the commission thanks the members of the work group, et cetera. But next to the last paragraph, simply state, so there's no misunderstanding on the part of the chair, that for the record, the Maryland Healthcare Commission has examined this issue and does not feel, I think, whatever language Mr. Sargent has. And that, I think, shuts, from our standpoint, we've done our duty.
Okay.
Okay.
No
Is
problem.
everybody here in agreement with that? Okay, that's it. Okay, thank you.
Thank you.
Any, okay, so now, one more.
Yeah.
I wanted to thank you for the excellent cat herding. I'm sure it was.
All right. But we have an action item. The action item is to approve the release of the letter with this addition to the chair of the House Health and Government Operations Committee. Do I have a motion? Motion, second. This is with the addition. Any further discussion, just to make sure? No further discussion? Okay. All those in favor say aye. Ayes have it.
Aye. Aye.
Yeah, okay. Right. There's nobody opposed, right?
Aye.
Absolutely. Very good. The letter goes forward.
That was a delay approve.
Oh, okay. Delay approved. Commissioner Thomas has made the point. Okay.
Thank you.
Thank you very much. Okay. The next item is the State Health Plan for Facilities and Services, Comprehensive Care Facility Services, proposed permanent regulations. Linda Cole, who's the Chief of Long-Term Care Policy and Planning, is going to present for our consideration as proposed permanent regulations, COMAR 2420, regarding comprehensive care facility services. Commissioners, COMAR 102420 will replace COMAR 102408, which covered comprehensive care facilities and special hospital chronic services. Now, in drafting these proposed regulations that we're considering today, staff considered input from the Nursing Home Working Group, which met 3 times in 2018. First on January 30th, then again on March 1st, and then again on October 4th. Staff has been very diligent in dealing with the industry, but also with members of the commission here, members of the commission who have made recommendations for these staff regulations. The draft regulations were released for informal public comment on June 6th. I understand that some industry parties have concerns about the proposed regulations. Several of you may have been contacted by representatives of the industry, but here's the point. The staff has listened to the industry over a couple of months through the development of the process and held the October 4th Nursing Home Work Group meeting at the industry's request. Now, there will be another opportunity for public input during the formal public comment period if we should adopt these proposed regulations. Now, if we adopt COMAR 102420 as proposed regulations. Linda will then present proposed regulations for COMAR 102408, which, if adopted, would apply to chronic hospital services. So let's turn right now to Linda's presentation on COMAR 102420. And Linda, when you finish, please remain at the table, because after we finish this, after we vote on this, I want to move immediately to the consideration of the chronic hospital service. Okay. All right. Ms. Cole.
Yeah.
Before
Before Linda gets started, I did want to just make some brief remarks about what the chairman alluded to. We did get a letter from the two trade associations who represent comprehensive care facilities, the Lifespan Network and the Health Facilities Association of Maryland, and they were joined by Lou Grimmel, who is the chief executive of Lorien Health Services, which is a system of long-term care facilities in Maryland. And they did request that we delay action on these proposed regulations and table them. We, as staff, are in favor of proceeding with the rest of this promulgation process, and are requesting that you adopt these as proposed regulations now. I think this is a little unusual, obviously. We don't always achieve consensus with stakeholders on state health plan regulations. It's not totally unprecedented, because I can recall at least one other time where we got such a proposal to table regulations as they were coming to the commission. I think my view of what's happening here is that we are proposing, for the first time in my memory, certainly, which goes back quite a ways here with the commission, some substantive changes in the way we regulate nursing homes. This has been a pretty stable regulatory regime, probably one of the most stable over the history of CON. And it's been very narrowly focused on regulating on the basis of maintaining high occupancy rates of nursing home beds. In this area, we really essentially have almost a request for proposal type of process. If we don't identify a need for additional bed capacity in the jurisdiction, then we don't docket applications and bring them to you for a decision if those proposed projects, would expand bed capacity in a jurisdiction. And with the declining use rates for nursing home services and gradual shrinking of overall capacity in this area, there have not been that many opportunities to expand bed capacity in any regions of the state. It's been pretty few and far between. So for the first time with this plan chapter, we are proposing to open up that process in a way that it has not been opened up before. We are proposing some what we call docketing exceptions, which under specific circumstances would allow proposals to come forward to you for consideration of expanding nursing home bed capacity in jurisdictions where we do not project a need for nursing home bed capacity. We don't think that those are radical in any way. We don't think that they're going to result in a lot of additional bed capacity being developed in the state. But I think there is concern that for the first time, we are really looking to change that approach to regulation. And related to that, I think the other second significant change, which we're proposing here, is to use quality measures in a substantive way in terms of kind of shaping the types of proposals that would be allowed to come forward, shaping, really controlling the types of applicants that would be allowed to come forward and establish new facilities or expand capacity in the state, but also using quality measures to actually open up for consideration some jurisdictions that have
a lot or, a fair number of poor performing nursing homes. And that obviously is based on the idea that we'd like to give consumers in these jurisdictions more choices of better providers. So change is difficult. It's always something that's a little scary. I think it's scary for the providers. It's scary for us to some extent to make these kind of changes. But I think the reaction that we're seeing on this particular regulation and the desire to slow down the process of change and to take more time is really coming from that type of change that we're proposing. So I just wanted to address that because we did have this rather unusual 11th hour request and just talk to you a little bit about that before Linda proceeds to actually talk to you in more detail about the regulation.
When did we put the chapter in place, the current one?
10 years ago, 2007, so actually 11 years ago.
It's not an incredibly fast process.
Yeah, Commissioner Pollak, how long did we advertise these changes? Did we publish these proposed changes?
What we did is we put together a work group, which first met at the beginning of the year. We had 3 meetings of that work group. After 2 meetings, we published a draft plan and went to an informal review and comment period. So that's what was released for informal review and comment. And then at our last meeting of the work group earlier this month, we actually reviewed the comments we received to that draft. And as staff, we spoke to our feelings about those. So we did preview what sort of changes we were going to make here in this proposed regulation.
And when did we receive this latest 11th hour?
Today.
I got a phone call about it yesterday. So same thing, 11th hour.
Mr. Chair, from the perspective of the CON work group, where topics within the scope of these have come up, we have tried very hard to say we're not talking in that work group about these regulation changes. In other words, we've tried very hard to not have overlap occurring. That's just one of many folks in the commission, but as chair of that group, I don't really see a reason to hold up of these reforms in light of what we're going to propose, because the more fundamental things would need to go to the legislature. The legislature may or may not act. It may act next year. That in the meantime, it would be a long time to not do something else if that's what we decided we want to do.
A wise observation.
The issue of the 2 work groups will be discussed as one of the.
Yes. Okay. Any further observations? Okay. Linda, thank you very much.
All right.
And thank you for your patience.
Thank you, Mr. Chairman, Commissioners. Today, I would like to present regulations for your consideration. The Comprehensive Care Facilities or Nursing Home Chapter is to be moved from COMAR 102408 to new codification of COMAR 102420. The existing nursing home portion of 102408 will be removed and replaced by the portion dealing with special hospital chronic services. Briefly, what I would like to cover today is the following. I will describe the process for developing these regulations, including work groups. I will highlight the new features of the chapter. Then I will focus on the major issues discussed during the informal public comment period, including descriptions of changes to the nursing home bed need methodology. And then finally, I will present next steps. Work on this chapter has gone on for some time. First, we met internally. We reviewed the current regulations based on our experience with planning and CON and updated it accordingly. We met with a small subgroup of commissioners at several meetings, and I would like to thank Commissioners Ness, Pollak, and Peters for their input. We convened a nursing home work group that included industry representatives, Medicaid, the Office of Healthcare Quality, and a consumer representative. And as Paul mentioned, that group met 3 times between January and October of this year. The informal public comment period was held from June 6th to July 13th. And as you recall, I presented a background and status report on the development of this chapter at the June Commission meeting. This slide highlights briefly the new features of the chapter. Under CON process, we added docketing rules to provide direction to applicants as to basic requirements for accepting an application. We added docketing rule exceptions, which are selected cases where a project may be accepted to address a specific issue in the absence of bed need. We also modified the waiver bed rules, known as 10 beds or 10%, in order to eliminate such beds if they're not implemented within 1 year. Certain themes emerge in this chapter. We encourage nursing homes to be major players in the continuum of care with strong collaboration with acute care hospitals as well as community-based services. As with other services regulated by the Commission, there is a focus on high-quality providers. This has been incorporated into both rules and standards. Consistent with the Medicare conditions of participation, the Commission encourages facilities to develop plans to meet the most recent Facility Guidelines Institute, or FGI guidelines, to provide care in less institutional environments. We also revised and updated the bed need methodology. During the public comment period, comments were received submitted by 4 organizations listed here: HVAM, Lifespan, Boyan, and the Office of Healthcare Quality, and the full set of comments is included in your packet. Although there were several pages of detailed comments, staff has tried to synthesize the major issues raised. These include timing of the update of these regulations while the CON task force is deliberating, requiring a minimal level of participation in Medicaid, known as the Medicaid MOU, use of the FGI guidelines with questions as to whether this duplicates the work of the Office of Healthcare Quality, use of nursing home compare star rating system for incorporation into docketing rule and exception, use of docketing rule exceptions to permit applications to be filed in the absence of needs, including a docketing rule that excludes for 10 years current and former owners, operators, and managers involved in fraud or abuse, and a request for a demonstration of the methodology. The question was asked, why should staff go forward with the proposed regulations when there is a CON task force currently underway that is making recommendations? Our response is that although the CON Modernization Task Force and the Nursing Home Work Group are being held during the same time period, they have different purposes and goals. The CON Task Force takes a broad overview of the entire CON process, including which facilities and services should be regulated and how the process should be modified. The chapter update involves working with current regulations and is considering how the nursing home regulations need to be updated since they were last updated in 2007. Also, the comment was made that this is the only chapter affected. As you recall, the Commission adopted proposed replacement cardiac surgery chapter at the September meeting, and we also note that staff has begun the process to update the psychiatric services chapter. So the Commission's planning and CON activities are moving forward while the CON task force continues its work. The second issue on this page is the requirement of a minimal level of Medicaid participation, commensurate with other facilities in a jurisdiction or region, whichever is lower. This percentage was reduced by subtracting the 25th percentile from the weighted mean during the last update of the chapter, and that formula is maintained in this chapter. An important focus of the Commission set out in its enabling statute is to ensure access to healthcare services. Access includes not only geographic access, but also financial access. The Medicaid MOU has been and continues to be a tool designed to improve financial access to nursing home care. Staff discussed this with the subgroup of commissioners who expressed support for retaining this provision. Furthermore, this has been a focus of a recent Joint Chairman's report, the interim report on nursing facilities discharge planning and assistance in obtaining financial eligibility for Medicaid, which raised concerns about nursing homes representing that they have no beds available for those who apply for Medicaid, and citing the Medicaid MOU as a site safeguard. In response to the comments, staff would recommend that the Commission include the provision about renegotiating the MOU if the applicable percentage changes. Staff also notes that both the current and proposed MOU standards permits an applicant to show evidence as to why this rule should not be applied. The next issue raised is the why use FGI guidelines and do these regulations duplicate OHCQ requirements. Although OHCQ has been working on updates to its nursing home licensure regulations, the FGI guidelines are not currently incorporated by reference. OHCQ has stated that the Commission serves an important function that complements its work. Also, in some cases, Commission regulations are stricter than OHCQ. For example, Commission regulations do not permit more than 2 residents to share a room or a toilet. OHCQ's current regulations permit 6 residents per room and 8 residents per toilet. The next issue deals with the use of nursing homes compare star ratings. Quality measures have consistently been part of the Commission's regulation of nursing homes. In the past, the chapter made reference to level 2 deficiencies. Since the state of the art has evolved, the Commission has standardized measures across a variety of settings. Although the star ratings may be an imperfect measure, CMS is consistently working to improve its accuracy. It is a measure that has been tested, validated, and approved by the National Quality Forum. It is used nationally to pay for performance and bundled payment models. Such measures also permit the Commission to assess the quality of an applicant facility who may not be located in Maryland. It is important to note that the rules in this chapter require facilities to meet minimum standards, that is, average or better. In response to the comments received, staff recommends that the Commission calculate an average of the overall star rating over a 2-year period, which is what the industry had recommended. That's 5 quarterly refreshes. In the informal public comment draft, we recommended 1 quarterly refresh, which is actually 1 year. So this recommended change should address concerns about fluctuation from 1 quarter to the next. There were general concerns by the industry with any docketing rule exception. These are circumstances where the Commission would accept applications in the absence of identified needs. 3 exceptions are included. First, if more than 50% of the facilities in the jurisdiction had an overall star rating of less than 3 stars, that is, below average or far below average, during the most recent 2 years. Second, if an existing freestanding nursing home that has fewer than 100 beds needs additional capacity to improve physical plant, financially feasible. And third, if the applicant presents an HSCRC-approved risk-sharing agreement between the nursing home and the hospital, consistent with the total cost of care model. So for these specific circumstances, this can permit an applicant to show need. The next issue on the slide asks why there should be a docketing rule applied to owners, managers, and management organizations for 10 years. The recommendation for the 10-year period is based on federal guidelines developed by the Department of Health and Human Services and the Office of the Inspector General. This also responds to situations seen by the Commission staff where previous owners or operators are often hidden in new corporate structures. In response to the comments, staff recommends that the Commission include wording similar to that used in the acquisition rules, which permits an applicant to show that all of the individuals involved in the fraud or abuse are no longer associated with the entity and that each entity has fully complied with applicable plans of correction. Although staff explained the nursing home bed need formula at the March 1st work group meeting, in response to issues raised by the industry, another meeting was convened on October 4th to address this and other issues. And I will briefly explain the methodology. The methodology was updated in response to the critique of the current approach. It continues to take into account use rates by age, but uses observed statewide rates of change. It continues to adjust for migration and includes both migration from out of state and from unknown origin, as well as migration among Maryland jurisdictions. It shortens the planning horizon from 7 years to 5 years, and it employs total rather than household population, and takes occupancy, which was previously a separate plan standard, and incorporates it into the methodology. This slide shows the dramatic drop in nursing home use rates expressed as days per thousand population, adjusted by age group. Although there's a slight increase in the under 65 population, this is more than offset by the drop in use by the 85 plus population shown on the far right, which uses by far the most patient days. As this slide indicates, there's been more than a 4% drop in the use rate in the oldest population between 2011 and 2016. Thus, despite a growing baby boom population, preference for services in the community means there's not a lot of bed need. This may be more detail than needed, but basically, once we obtain base year use rate by age group, we project a target year use rate and patient days based on the statewide rate of change over the past 6 years. This is then adjusted first to account for migration into Maryland from out of state and those with unknown origin, and second to account for net in and out migration among Maryland jurisdictions. The adjusted target year need is then checked for 90% occupancy and recently opened facilities. Positive bed need is shown in the highlighted rows, and this is the bottom line of all of the calculations. It's shown in the highlighted rows in 3 jurisdictions. 2, Calvert and Charles, are eliminated due to them being below the 90% occupancy standard. An additional one, Prince George's County, is eliminated due to the recent approval of a new facility in Prince George's County. Staff recommends that this facility be provided with time to ramp up and become operational, so these patient days and occupancy can be included in the next bed need update. So currently, there's no bed need projected. Finally, staff requests that you adopt COMAR 102420, its Comprehensive Care Facilities chapter, as proposed permanent regulations, and replace the Commission's current nursing home regulations contained in COMAR 2408. Staff also requests the Commission repeal existing COMAR 102408, removing all regulations regarding nursing homes, contingent on 102420 becoming effective as final regulations of the Commission, and replace it with 102408, state health plans for facilities and services, special hospital chronic services, which is comprised of replacement regulations that address chronic hospital services currently contained in 102408. With this action, the regulations will be published in the Maryland Register, and the promulgation process will begin, including a formal public comment period. We will then return for final action. That concludes my presentation. I'll be happy to answer questions.
Thank you very, very much, Ms. Cole. Commissioners, do you have any questions for Linda Cole? Yes, Commissioner Pollard.
So, first of all, Linda and Paul, thank you for a tremendous amount of work, outstanding work group product and evaluation and process. I just want to repeat something that I mentioned I think a couple of times in the work group for the public record. I think that at a ground floor level, at inside hospitals on a day-to-day basis, what we're seeing is difficulty getting patients out the back door. Difficulty finding enough places to put patients in skilled, when they qualify for skilled nursing facilities, getting them to accept the patients. We find there are restrictions on the severity of the illness, on the particular demands of the patient, and some of those don't show up in bed need projections. And I think that there's enough in these regs that gives us some flexibility to move beyond the bed need projections, not as much as I would have liked perhaps, but at least better than we are now in terms of moving past those bed need projections at times to create the capacity that's necessary to take care of our patients, because our hospitals are constipated, for lack of a better term. And I, like you, received last minute calls from some industry participants who had some concerns about these regs, and I fought them back. I think they would testify if given the opportunity, which they weren't. But the one thing that I wanted to get you to clarify for the minutes, if you could, and I think this will help allay some of the concerns, although not all of them, is the question of the degree to which these new regulations allow the commission to proceed with docketing a CON request in the absence of a favorable bed need projection, but in the context of a risk-sharing partnership between a facility or proposed facility and a hospital or health system that's intended to reduce total cost of care for a given population. It's my understanding in reading these regulations and in our discussions that led up to this, that the requirement is that the facility that is submitting the application has to demonstrate that the need that they're defining can't be met by the existing inventory, can easily be met by the existing inventory of beds.
Right, it says.
I think that's written clearly there.
Right, the applicant shall demonstrate that a project adding additional bed capacity in a jurisdiction is necessary in order for the cost reducing agreement between it and the hospital to be implemented.
Right. So can you describe how, in reviewing an application, how you would, what you would consider adequate demonstration of that? What would they have to do?
Well, I think from my perspective, I think what we would expect to see is the hospital, as part of the CON application, explaining what sort of communication it had with existing facilities, what attempts it made to develop a similar type of arrangement with existing facilities, and what facts can it present to demonstrate to the satisfaction of the commission that it just was not feasible to meet the objectives, the cost-saving objectives that it was trying to meet by working within the constraints of existing facilities and their existing bed capacity. So I would be primarily looking toward the hospital as the partner with the applicant to really adequately demonstrate that.
And if we could get that included in the minutes, I think that would help at least get the this proceeding. That would help to have the those with concerns about proceeding with this regulation now. That would help allay those concerns, hopefully.
Commissioner Sargent?
I don't disagree with the substance, but just Commissioner read it. It doesn't. When it's part of the regulation we're talking about, I just didn't see a sentence that said that even if there was a need, you could still go ahead and you've got the copy.
Page 10.
Huh?
Page 10 at the top of the page, letter E, before the bold C.
Got it. It's been around. Sorry.
Okay. Go ahead.
I did have a question about FCI. If I understand Lorian's comment was two parts. Is why is the commission requiring it, and why isn't it already covered by OSTC? And our response was why it's not already covered by OSTC. But I didn't see anything in our response about why are we requiring this specific design standards for nursing homes?
It's not incorporated in the OHCQ guidelines. I believe it was at the CON task force that OHCQ said that it felt that the commission serves a complementary function because they're the gatekeeping function in terms of the quality providers that come in, and then they can maintain that oversight.
So I guess I was asking a little more fundamental question. Assuming the OHCC is not doing it, it's not duplicative. The first part of that is, should we be doing it? Why are we requiring it? Not them
put it
at all.
in their new regs. The new regs have not been implemented yet. They propose them to be in their updated regulation.
Okay. So I mean, I'm sorry. I don't really mean to press the point. Well, should we be requiring specific design standards? Period.
So let me give you my perspective on this. A few years ago, that's, for me at least, that's when I felt we really needed some design guidelines because of the ambulatory surgery facilities. Maryland, because of the way we've structured CON regulation, has lots of ambulatory surgical facilities. more per capita than any other state in the country. And we were seeing some pretty strange, designs coming through. There were no licensure standards that incorporated the FGI guidelines by reference. And I would say that most of the facilities we saw were being designed by architects who were paying attention to those guidelines, but we did have a few that were not. And so that's the first time that we actually imposed those in our state health plan and saying that, you have to use these guidelines to design ambulatory surgical facilities, and you can't deviate from them because they're guidelines. But we want you to tell us where you're deviating and maybe need to deviate because of the space you're working with or the particular requirements of what you're trying to do, and let us evaluate that. And we have even gotten opinions from FGI on those deviations and how they felt about them. In the hospital side, those are incorporated by reference by OHCQ in the licensure standards for hospitals. And as Linda just mentioned, I think that ultimately we'll probably get some updated licensure regulations for nursing homes that also include these FGI guidelines as a design requirement for nursing homes, because they have actually included them in draft regulations that have been held up for quite a while. I'm not sure when that's going to happen, but our feeling was that it made sense for us to more or less incorporate those by reference for all of the facilities we regulate, because it is a national consensus document on how healthcare facilities should be designed.
So that was sort of my next question. Since I'm not familiar with the standards, are these sort of basic standards that everyone is complying with, or is it a standard that's a stretch and we're going a little farther than usual? I'm trying to evaluate whether how much of a requirement complying with FGI is in terms of everybody's doing it. It's a broadly used standard. There's really not another one. It's a new standard, or it's just one of many. It's coming out there from sort of put it in that constellation of
I think it's general guidance. For example, if you have a specialized unit, if you're serving Alzheimer's patients, what is the best design for that type of patient population? Similarly, with how many patients per room, having a less institutional environment. So there are basic guidelines on how to design the facility.
And are there other standards? Are we choosing these over other standards, or is it FGI is really what's out there and with no standards for FGI?
FGI is it. Okay. It was originally the Academy of Architects guidelines for a number of years, and really the Academy of Architects really went into this business of developing guidelines like this back in the 60s when Medicare and Medicaid came into existence. That's when there was a need or a felt need to have some sort of kind of national consensus on these design guidelines, and they've been updated regularly ever since. And there really isn't any competition. This is what healthcare facility architects use.
Thank you. That's very helpful.
Any further, Commissioner Reimer?
What is the reason for the volume decline? Do you know that?
You mean the use rate decline? Basically that people prefer to receive care other than a nursing home. I mean, there's some increase in subacute care. People go into the hospital and they need rehab for a couple of weeks. But what we saw in the past in terms of long stay residents living in a nursing home for years, there's a preference for services in the community, getting home health, living in assisted living. So there's just a decline nationally.
Right. And is it a cost issue? I mean, nursing home costs per day compared to other types of, at home, providing at home care.
I think it's more personal preference.
And some of the things we talked about, was brought up earlier, was on my question, was about that, basically determining the size of how many beds per room, how many bathrooms per room. Obviously, some of it is a cost issue. I mean, I don't know what the difference by providing a facility that has two patients per room with one bathroom versus 4 patients per room for one bathroom. based on the type of patient that's in that room. Okay, obviously, if they're a higher level of care, maybe it should be 2. If it's a lower level of care and then more of a long-term care, it's going to be 4 because it's going to be a lower cost. So some of this issue, again, comes back to patients don't qualify for medical assistance. They got to go on spend down, use their own resources to pay for this care. Whether or not we should give them some lower cost options that might be available, and give nursing homes the ability to maybe provide 2 different kinds of wings. One is a more of a longer term wing that has patients in different conditions as opposed to the ones that need higher level of care. I don't know. So when I read that, I sort of said, now we're starting to get a little more restrictive where you can only have 2 patients per room. Is that something that we should adopt in the policy format, or do we give ourselves more flexibility to say, well, maybe we're not going to do that for other reasons?
Generally, in the current plan, we require, if there are facilities that currently have multiple bedrooms, we require, if they're renovating them, to try to reduce it to 2 bedrooms. Given the fact that these are elderly, often incontinent patients, to have 4, 5, 6 patients in a room sharing a toilet is a very difficult way to live. I know that we've discussed with the industry having private rooms, which hospitals have, and they're saying that's cost prohibitive. Yeah. So for the most part, they have 2 bedrooms.
Okay. So I have not read the old regulations. Does it say in there that two patients per room?
Yeah. That's the maximum that we've used for a long time. I think that's not a controversial standard, and that doesn't change things overnight. Just as with people come through here with capital projects, don't want to see 3 bedrooms or 4 bedrooms. Okay. And to your point, what we do see, and as the use of nursing homes for rehabilitative care, so these are Medicare patients generally who are coming out of the nursing home, spending a couple of weeks there getting rehabilitation. That's a growth area. The longer term patients who really aren't getting very much rehabilitation, their care is more custodial, and typically, if they don't start out as Medicaid patients, become Medicaid patients, that's where the decline is occurring. And that decline is so great that it's offsetting the growth that we see on Medicare. So overall, we're seeing a decline in demand for these beds, and for the capacity is shrinking for that reason. But you do tend to see nursing homes reorienting their facilities so that they have a wing that is for the shorter stay rehabilitation patient. And typically those are mostly one bedroom. But in the more custodial care wing of the facility, you will tend to see more semi-private.
Any further questions? Okay. No further questions. The action item. Oh yeah, sorry. I keep forgetting. Is there anybody on the phone that has any questions at all?
I don't have any questions, Commissioner Moffett. I'd just like to thank Linda for the work that she's done on this. It was a ongoing, lengthy process. Lots of compromise going on there. I know that the industry has different issues, which they'll probably continue to address. But at the end of the day, I'm pretty confident we'll get to a place where everybody will be, at least for the most part, happy, with some folks probably being a little unhappy, but that's the way change occurs.
It's true. We can't make everybody happy. Okay. No further questions. Then the issue is the approval of COMAR 10-2420, State Health Plan for Facilities and Services, a comprehensive care facility services, proposed as permanent regulations. Do I have a motion to approve the staff recommendation to approve the regulatory change? Marsha Boyle, Commissioner Pollack. Are there any further discussions on the motion? Okay, no further discussion. All those in favor of approving COMAR 10-2420 as proposed permanent regulations, please say aye.
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 Aye. Any opposed? Okay, the regulations as proposed permanent regulations are approved. Linda, I want to thank you very much. I share the views of my fellow commissioners that you've done an absolutely wonderful job on this, and we really appreciate everything you've done. But don't run away.
Now we have the next.
No. The next action item is COMAR 10-2408, the State Health Plan for Facilities and Services. This is Special Hospital and Chronic Services. And again, we are talking about approving proposed permanent regulations. Linda, present the agenda item.
It's basically repealing the nursing home component of 10-2408 and replacing it with the remainder, which is special hospital chronic. So that will stand.
That's basically it, yes. Are there any questions from the commissioners for Linda? Commissioner Sargent.
Are we changing, is it just reapproving the remainder, or did we revise them?
There are slight revisions, like the introductory part has been updated with the statute. There's the definition section, but primarily the standards, which are one page, are basically the same.
Right. Yes, you've all received copies of the draft proposal. We're talking about a very thin set of regulatory changes. Okay. Any further questions? Okay, no further questions. Do I have a motion to approve COMAR 10-2408 proposed permanent regulations? We have approved, yes, Commissioner Pollack and Commissioner Peters. All right, any further discussion on the motions? Okay, that being the case, all in favor of approving these as permanent proposed permanent regulations, say aye.
Aye.
Aye. Are there any opposed? Okay, the proposed permanent regulations are approved. Thank you, Linda. Thank you very much. Okay, the next item is the approval of a new member for the Cardiac Services Advisory Committee. Eileen Fleck, Chief of Acute Care Policy and Planning, is requesting approval to add James Ricabo, Clinical Manager for the Cardiac Cath Lab at Meritus Medical Center, to the Cardiac Services Advisory Committee. Eileen?
Thank you. Good afternoon, Mr. Chair and Commissioners. So you received a copy of his CV, I think, in your packet. I'll just review a little bit about him. James Ricabo is the Clinical Manager of the Cardiac Catheterization Lab, the Cardiac Rehabilitation Department, and Radiology Nursing. He manages all aspects of those services and has been in his current role since 2013. He has previously worked as a nursing supervisor and an emergency department registered nurse. He has a Master's in Science in Nursing Leadership from Western Governors University and a Bachelor's in Science in Nursing from George Mason University. So at this time, I'd like to request that the Commission approve his nomination to the Cardiac Services Advisory Committee.
Okay, thank you. Are there any questions for Eileen? Any questions at all? Commissioner? No, none. Pardon?
I'm ready.
Oh, you're ready. Okay. I have a motion to approve the appointment. Motion. Second? Second. Very good. Okay. No further discussion, I take it. All those in favor of adding James Ricabo to the Cardiac Services Advisory Committee, all those in favor say aye. Oh, just a moment.
Aye. Aye. Aye.
Any opposed? Okay.
Thank you.
Eileen, tell him he's appointed. Okay, thank you. Okay, we'll have an overview of upcoming initiatives. Ben?
Yeah, thank you all for actually a reasonable meeting today. We've got through in 2.5 hours, which given past performances is something that I'm happy to give you back a little time. For November, we have probably a fairly ambitious agenda at this point. We will be having a routine action for this time of year. We'll consider release of the medical care database data submission manual. That's the manual that insurance carriers and PPMs use in submitting the data that goes to the medical care database, the APCD. We are required to update that annually. We have been engaged over the last 6 months with a vendor that's looked at the feasibility of using a diabetes measure developed from the medical care database data and the Johns Hopkins ECG clinical methodology to develop metrics for measuring the prevalence of diabetes. That's important because prevalence of diabetes will become one of the population health measures going forward beginning in 2019. It's very closely, it's focused on the Medicare population specifically, and population health credits will be awarded to hospitals who make improvements. But as we were talking about population health, we're talking about all populations, and there's a desire to consider whether we can have parallel measures for the privately insured. This is not necessarily results, but a demonstration that it is feasible that we'll present to you. We'll also, foreshadowing some questions earlier today on the trauma fund, we'll present the annual report on the performance of the trauma fund. We'll also likely consider one additional advanced directive application from a vendor who is also interested in offering these services in the state. As usual, several CONs, and we likely will also update you on the Leapfrog report, which will come out shortly after November 1st, as well as our Network for Regional Health Initiatives Total Cost of Care Collaborative. This is the third year we're doing it, and as in past years, we expect some favorable performance relative to our colleagues in other states. And then, of course, we'll spend some time talking about the recommendations that will come to you in draft form from the CON Modernization Task Force. So a fairly lengthy agenda. I also, before I end today, I want to thank the 4 commissioners again that served on our commissioner work group for considering changes to regulations. This was the first time we tried that, and consistent with feedback that we've gotten in the past, that commissioners want to have an opportunity to weigh in on regulations as they're being developed. I think it was, in general, we can say, very helpful to the staff and provided opportunities at an earlier stage than usual where commissioners can offer input. So thank you to those commissioners, Commissioner Peters, Commissioner Metz, Commissioner Pollack, and did I miss anyone? There's a 4th commissioner. Who did I miss? Commissioner Flagg, that's correct. So thank you all. We'll be looking to continue that process.
Thank you. Any questions for the director at all? Okay, well then, all good things come to an end, and so does this meeting. So may I have a motion to adjourn? No, very good. Is there a second? Does anybody want to stay for longer? All those in favor say aye.
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 Okay. None opposed. All right, let's go home. Thank you very much.
Bye-bye. Safe trip.
Bye.
Bye-bye, thanks.